Hi, it's Dr. Ali, continuing a series of lectures for medical students and residents who should take the trouble to verify the information for themselves. Today, we're going to cover hereditary thoracic aortic disease, which could have two different clinical manifestations: aneurysm, which is gradual dilatation, or dissection, which is an acute internal tear. There's a progressive failure of the aortic media. Chronic matrix degeneration determines the weakness. Acute hemodynamic stress determines the fate. The aortic media comprise the collagen, which you could think of as a steel rebar, provides the tensile strength. Fibrillin, which is the scaffolding, organizes fibers and binds TGF-beta. Elastin, or the rubber bands, allows systolic stretch and diastolic recoil. Smooth muscle cells, a maintenance crew, continuously synthesize and repairs the matrix. Loss of smooth muscle cell leads to overactive matrix metalloproteinases, elastin fragmentation, medial degeneration, historically called cystic medial necrosis. The HTAD genetic spectrum, 20 to 30% or a third of aortic aneurysms have an identifiable genetic basis. This could be syndromic or non-syndromic. Syndromic has aortic disease with systemic features such as marfan syndrome, which has arachnodactyly, lens dislocation, mitral valve prolapse, has the FBN1 gene mutation, or the Loeys-Dietz syndrome, which is a bifid uvula, hypertellurism, aortic tortuosity, early dissection, associated with the TGFBR1 and 2 gene problems. Vascular EDS, characterized by translucent skin, early uterine or bowel arterial rupture, associated with the COL3A1 gene. The non-syndromic HTAD has aorta-only manifestations, involves the ACTA2, MYH11, MYLK, PRKG1 genes. Patients appear physically normal. The hidden clues are a strong family history, sudden and unexplained death, dissection. Each one of these genes controls a different aspect of the aortic media. Notch1 gene mutation is involved with bicuspid aortic valve. It's the most common congenital cardiac anomaly. 40 to 60% develop ascending aortic dilatation. The first hit is a genetic weakness causing immature smooth muscle cells with a poor matrix, genetically weak ascending aorta. The second hit is a hemodynamic stress due to eccentric high velocity systolic jet. Then there's accelerated failure, accelerated aneurysm, early calcific cardiac valve disease. The aortopathy is intrinsic. Clinical takeaways in management: image the entire thoracic aorta in all bicuspid aortic valve patients, screen first degree relatives with echo CT-MR, reduce the stress with beta blockers, angiotensin receptor blockers. Beta blockers lower heart rate, DPDT. Angiotensin receptor blockers attenuate TGF-beta signaling. The surgical threshold, 5.5 centimeters for standard, 5 centimeters for marfan with the FBN1 gene or bicuspid aortic valve, earlier if rapid growth. 5 centimeters for marfan and Loeys-Dietz syndrome, which are at high risk for catastrophic dissection at much smaller diameter. Thanks for watching. More to follow.